Hello, and welcome to the Clinical Care Options Medical Specialties Podcast. I'm your host, Sarah Anderson. In this episode, Dr. Jennifer Green from Duke University School of Medicine in Durham, North Carolina, and Dr. Carol Wysham from the MultiCare Rockwood Clinic in Spokane, Washington, have a conversation about key points related to incretin-based therapies and how to talk to patients about these topics. Now, let's get started and hear Dr. Wysham and Dr. Green discuss the buzz around incretin-based therapies.
Jennifer, it's nice to have this opportunity to share this exciting topic with you today. You know, there's been a huge buzz about the incretin therapies, specifically GLP-1s, as well as the dual agonist GIP-GLP-1. Could you share your experiences with what you perceive as the benefits of the GLP-1 or incretin therapies?
Of course. I'll cover the top line results. And you know that these medicines were first developed as essentially glucose lowering therapies for people with type 2 diabetes. And they're very effective in achieving that goal for almost everyone to whom they're prescribed. But of course, the drugs also have a nice added benefit of promoting weight loss. And the degree of weight loss can vary by agent and by the person who is using the medication. But these medicines really represent a revolution in how certainly we treat type 2 diabetes. And then more recently, both of those classes have become available as treatments for weight loss specifically, even in people who don't have type 2 diabetes. And in my experience, these are very, very effective interventions in helping people to meet both their glycemic and their weight goals.
The ability to help our patients with diabetes, as well as without diabetes, lose weight has been just a game changer for us all. But I really like to also emphasize the fact that the majority of our patients who have obesity have multiple other comorbidities that are potentially improved with these medications. And I can think of a patient I saw yesterday, lost about 65 pounds with tirzepatide. She is no longer taking her omeprazole for heartburn. Her joints feel better. She's off her CPAP mask. She's stopped her antihypertensives. And she can exercise. And so her mental status, or mental health is also improved. So I think it's important as we look at our patient in total, that we look at all of the obesity comorbidities as we're making our decisions about which medicines to use for diabetes, or, if we're treating obesity, which ones to use. And there, as you said, there's a difference in magnitude. So we might be wanting to really push for the most effective agent in the patient who has the most comorbidities. Someone with less serious comorbidities may be able to use one of the medications that have perhaps less effects or less side effects.
Yeah, I agree. In my experience, I've had many patients who have had essentially lifelong struggles with weight tell me that when they started taking these medications, it was really the first time that they hadn't thought continuously about eating, about food. And so to a certain extent, yes, the medicines make you less hungry, but for many people in my experience, it then provides them with some positive reinforcement that they can make a change. And I think some of the weight loss that we see is essentially that people feel empowered to make healthier choices. But of course, it's not all a bed of roses. So it's important that when we talk about these classes, that we keep in mind what the likely side effects will be and what other perhaps less common adverse events might occur in people prescribed these medications. So Carol, do you have any insights into both the usual side effects that we might expect with use of these medications and maybe any sort of recent developments or concerns?
I think all of us who have taken care of patients who have had substantial weight loss have been aware that hair loss is common in people who lose a lot of weight. So I don't think that is the side effect of the medication, but just a, quote, side effect of the weight loss. And you could similarly say the gallstones that have been reported. Probably also a specific side effect of weight loss. And then finally, remember when people lose weight, their bone density goes down. Although I haven't seen any reports of that, I would be not at all surprised to see that people report a reduction in bone density just simply because of decreased mechanical stress on the bones. The suicidal ideation is obviously something that was reported to the FDA, EDRS system. And as you know, that's a spontaneous reporting system. There's no way to balance if it's related to the medication or if it's related to, underlying situation. What I will explain is that the data, looking at some of the current studies and looking at some of the reports, there does not appear to be an increase in suicidal ideation. In fact, quality of life scores generally go up in patients who are treated with these agents. Now, saying that, I do think that there is a group of patients who really are dependent upon the hedonistic effects of eating for their mental health. And there may be a small proportion of patients who you could see, a decrease in their mental health quality of life. But I think we can screen those patients out just by asking the simple questions of what drives their eating and what their relationship is with food, which I think is important.
Absolutely. And I think it always is a good idea for us to at least briefly discuss the potential for that to occur, along with the more common side effects when we're starting someone on the medication or up titrating the dose, and to periodically check in with their mental health, because should a problem occur with prompt intervention, hopefully we can prevent any sort of serious occurrences from happening in people using these medicines, or really any medicines at all. So I think this is a manageable risk, but you're right. Maybe there are select individuals in whom use of other medications might be more appropriate.
I think this could be a legacy of some of the other mental health issues that were described with older weight loss drugs. And so, anytime you say, oh, there's a weight loss drug and a person has a mental health issue, you might be more inclined to tie it to that just because of the legacy from the older medicines.
Absolutely. But remember that these new incretin-based therapies, their mechanisms of action are very, very different from other types of historically available weight loss drugs. So they're really not comparable, and potentially have a much lesser risk of causing mood changes than, for example, the drugs available in the past that worked through the endocannabinoid system. So a whole new classes of medications. I agree that the FDA should, of course, routinely review the reports of adverse events that are occurring in clinical practice. But at present, data, as you've mentioned, that have been published, including survey of outcomes in very large EHR data sets, do not suggest an increased risk of suicidal ideation or suicide, and might even suggest perhaps less of that in clinical practice. But let's take a step back and talk a little bit about the more common side effects of the medication, and that is the potential for these medicines to cause GI side effects, including most commonly nausea, potentially vomiting, loose stools, or constipation. And there are a variety of different ways, I think, that we've been successful in helping our patients reduce the likelihood of these GI side effects occurring, and how to, in fact, make them a bit more tolerable so that the patient can successfully stay on a therapeutic dose of the medication. Carol, do you have any special tips or suggestions for our audience that you have found helpful?
Yes, thanks for that. I'm very interested in this because obviously we want our patients to succeed, and succeeding means they need to tolerate the medications. The very first thing I usually start with is to explain the frequency of the side effects. So 20% or so of patients are going to experience some degree of GI side effects during the initiation and titration of medication. But I like to flip that and say 80% of patients don't have any side effects. So let's just start from that. Certainly, the slow titration is very helpful, and there are some studies that show that even slowing the titration down, even starting lower and going more slowly, can improve the GI side effects. So I oftentimes talk to them about that, and if they don't tolerate one, we can always try another. That doesn't necessarily always translate to the entire class. But as far as, what I ask them to do, I ask them to use smaller plates to try to decrease their fat content of their diet, which oftentimes they have less desire for fat anyway. So that actually is pretty easy for them. And then to stop with one serving for at least 15 minutes, go fold the laundry or, go do the dishes. And then if you're still hungry, of course, go ahead and have a second serving. But so many people are eating so fast that they blow right through their ability of their brain to tell them when they've had enough to eat. And I think overeating also really accentuates some of the GI side effects, the nausea, et cetera. Always found it really interesting that you could have a drug that could cause diarrhea and constipation. And I think the diarrhea, I think it was you that pointed out to me first, could be just accentuating the metformin side effects. So sometimes you could think about either preemptively or in response to diarrhea, trying to decrease the metformin. But the constipation issue, I think we both agree is likely related to just not eating as much. They have a lot less bulk of food, so they have less frequent bowel movements. Now, that may not be constipation, but in their view, it's constipation. So increasing fiber content, even fiber supplements, I think is really helpful in that setting. How about you? What is any other thoughts that you have?
Yeah, I'll tackle the constipation first. I mean, I think that was a side effect that really wasn't on people's radar at first. But in my experience, when I've asked people about the frequency of constipation after starting these medications, it's actually fairly common. The good news is that constipation is generally a little bit easier to address, for example, than nausea and vomiting or even diarrhea. So as you've mentioned, making some changes to include more fiber in the diet and making sure that they're drinking plenty of fluids too can be very successful in making sure that people are comfortable. And the other thing I'd just like to emphasize, and you have mentioned it already, is of course, starting with the lowest dose and going slow in the up titration. Remember that the up titration schedule that is provided and recommended by the manufacturers of the drugs, that's the fastest or the most rapidly you should up titrate the doses. And just because you can up titrate the dose, for example, of semaglutide after a month, that doesn't mean that you must do that. And in fact, some people can't tolerate up titration to maximum doses. And I personally like for my patient to be really feeling well and not feeling sick before we go up on the dose. And sometimes that'll take, for example, 3 months rather than 1 month for them to adjust to their current dose of medication. And it's only when they're feeling well that I'll up titrate. And I think that's been a very successful approach in my patient population.
Jennifer, we've talked a lot about the pros and the cons of these medications, but in reality, there are non-responders to these medicines. What's your experience with that, both the GLP-1s as well as perhaps the dual agonists?
Yeah, that's an excellent point, and I think it is very important that when we are talking about the use of these medications with patients, that we be realistic about what they can expect, and for them to understand that in particular, the weight loss effects may be fairly modest, and they're a little difficult to predict when you're starting the medication. So it is important that people understand that maybe about 15% of people who start GLP-1 receptor agonists are considered non-responders. This is probably more common, again, with the weight loss effect than with glycemic control. In my experience, this is probably less common with the dual incretin agonist tirzepatide than with the GLP-1 receptor agonist, but I'm sure that there will be non-responders to dual and multi-incretin agonist therapies as well. In my experience, though, it's important to remember that if you have a patient who is already close to their glycemic goal and they start one of these potent medications, their A1C might not come down very much. It might not be appropriate for that to happen, but they might be able to stop a lot of their other glucose-lowering medications. So I would consider that to be a glycemic response. It doesn't necessarily need to be that their glycemic control improves, but that you can continue to control their glycemia with fewer medications.
I think that's really a good point because, when the FDA looks at what a medication and whether or not it is going to be approved for reduction in glucose, it's looking just at the A1C change, but not taking into consideration that the patient may not any longer be on agents such as insulin or sulfonylureas, or, they don't look at the details. And there's certainly those patients in whom we've been able to eliminate insulin, and which is, of great benefit to them in terms of their safety. So I totally agree. Not all non-responders are truly non-responders. It depends on your definition. That's really helpful. So when you're talking to your patients related to their response and what to expect, how do you counsel them in terms of what weight loss to expect? What's a success when you're starting these agents with them?
That's a very good question. And I never, ever promise that they're going to lose the same percentage of body weight that was seen in clinical trials, but because we know that that's sort of the optimal environment. So in clinical practice, the degree or percentage of body weight loss that we would see with use of these medications would be, I expect, a bit lower than seen in clinical trials. I do also encourage them to continue to pay very careful attention to what they're eating and the amount that they're eating. These are medicines that will make them feel less hungry, and they will eat less. So I try to emphasize that they need to make sure that what they are eating is to the best of their ability, sort of high value foods. So, but there are some people, and you've seen this yourself, some people who start these medicines and feel markedly less hungry. And when they feel less hungry, they reduce their caloric intake very, very significantly from baseline. Those people are going to lose a lot of weight. Other people notice, I think, a lesser effect on with respect to the degree of satiety that they feel on these medicines. And some people will not necessarily cut back very much on how much they're eating. So it's always helpful, I think, to make sure that we encourage use of these medicines in the context of appropriate lifestyle modification. When they start these medicines, it doesn't mean that they don't have to pay any attention to what they're eating. But I don't usually tell them or a certain amount that they can expect to lose. I do indicate, though, if we're using it for weight loss purposes, as with all weight loss medications, I would expect to see at least a 5% loss of body weight within about 12 weeks to really be confident that the medicine is having a beneficial effect. So that is the minimum that I would expect them to lose in order for me to decide that they are actually benefiting from the medication. But that's a long answer that really says I don't guarantee a certain amount of weight loss.
I'd actually like to kind of turn that a little bit and talk about what some of the downsides of this extensive weight loss can be and how we can mitigate it. So I have a very elderly population in my practice, and I am, aggressively using these medicines for cardiovascular benefit as well as, all the things we've talked about. But I'm very concerned about the potential for frailty in the older patient with weight loss. How do you address specific recommendations for your older patients in order to minimize that risk?
Well, that's a very good question. And we know that when people lose weight, in general, they lose about 25% lean body mass, and that includes muscle. And many of our frail older patients don't have a lot of muscle mass to begin with. Some of the interventions that have been recommended to minimize the degree of loss of lean body mass would be to ensure that the patient is eating a reasonable amount of protein each day. They may need to see a nutritionist or dietitian to assess that and talk with them about ways to introduce enough protein into their diet. And resistance exercise has been recommended as well. But I have to say that these are interventions of unknown efficacy at this time. Perhaps in our older patients or patients who are already somewhat frail, we need to be very conservative about the degree of weight loss that we expect or recommend or would prefer in order to avoid worsening their frailty.
Yeah, I think that's really important. I also encourage patients to work on balance and then specifically core strength exercises with yoga or Pilates or even chair yoga, Tai Chi, something so that they can improve their or decrease their risk for falling, because I think that's one of our biggest concerns.
Absolutely. So we've talked about the benefits of use of these medications. These are medicines that we're prescribing for chronic diseases, that is diabetes or obesity or both. Do people need to stay on these incretin-based therapies forever? What are your thoughts?
Well, when patients always ask that, and my answer is, well, I look at it as being indefinite. I said, we treat your blood pressure. You're not expecting to come off your blood pressure medicine. Similarly, with diabetes, we don't anticipate, even with a great weight loss, that you will be able to come off these medicines and still maintain your glycemic control. I think the biggest question is related to weight. What if a patient comes down, they've had a successful weight loss, they've reached their nadir and they're leveling off? What now? And, I think the simple answer is you continue. But I think we're all intrigued with the possibility that we may be able to at least back titrate the medication and help patients maintain that healthy weight. Stopping it, clearly the weight rebounds. The studies with both semaglutide and tirzepatide don't quite go back to baseline, but maybe if they continued to follow those patients longer, it eventually would. So we know that we can't stop them. I've had a few patients who actually lost more weight than I thought was correct. And I did back them off and they're doing fine, leveling off on, half the dose that they were on before. But I haven't really in large numbers tried to back off on these medicines because most of my patients I'm treating for diabetes.
I agree. So one of the ways I've heard the effects of these medicines described that is easy to remember is that they seem to change the set point at which your brain is happy with your weight. And we're generally giving these medicines to people whose set point is very, very high. It is not at a healthy point. And when you take the medicines, then essentially your brain, your hypothalamus becomes comfortable with a lower body weight or BMI. And then when you withdraw the medicines, then things revert to their usual pre-treatment state. So I agree. I don't think that these are medicines that will be successfully used in an intermittent fashion. But once people have really had a robust metabolic response, that reducing the dose would be appropriate. And particularly for the person in whom we're concerned about frailty or people who've been on these medicines long-term as they age, that may be a very, very appropriate therapeutic response. So I think we've saved the most controversial topic for last, and that is access. We know that these are medicines that cannot be accessed by everyone, and this is not just a financial issue. There are supply issues too that can affect the availability of these medications, even for people who are taking them for serious chronic diseases such as diabetes and obesity. So I would like to point out that in particular, those with Medicare may face the greatest challenges. Of course, if they're taking a GLP-1 receptor agonist for diabetes management, they still will have concerns about issues about access to the medications once they reach their donut hole. And Medicare coverage of obesity services and treatments includes quite a lot with respect to screening and counseling and availability of bariatric surgery, but not medications that are prescribed specifically for weight loss. So we know that there are individuals who will definitely have challenges in accessing these medications for weight management per se, or may not be able to access them at all. And in my own state, North Carolina, what we've seen very recently is that the state health plan has in fact stopped providing coverage for GLP-1 receptor agonists for weight loss specifically. So it's becoming very challenging for certain groups, again, those who have Medicare coverage, and those who have specific types of other coverage to access these medications. And Carol, do you have any tips or tricks, or can you discuss a little bit what people might be turning to as alternative means of accessing these medications?
Well, there's a couple of things that I frequently recommend, particularly for my Medicare patients when I'm treating for diabetes. So that's really where I'm focused. We have very poor coverage in our area for weight loss. So really focusing on the diabetes treatment, there is the ability to use particularly those GLP-1s that dial up. You can use smaller doses. You can titrate it more slowly. There's ways to decrease the cost by kind of doing things off label with the dialing up doses with larger pens. And I do that very frequently with my patients. The other issue is just knowing what's covered. I know that the Air Force Base covers dulaglutide, and I know that our first choice on the state health plans is liraglutide. And so just knowing what to expect, but also knowing what the steps are. So yes, I tell patients, we're going to need to start with this. If you don't tolerate it, don't have good success, we can always get this approved. It is a possibility. So really understanding, and I think it's fairly limited number of health plans that we really need to keep our hands around. I think the issue with access because of availability, because of shortages, is a much more complicated situation. And we basically came up with a smart phrase in our EMR that when we have that problems, asking people to call around to different pharmacies and, let us know, and we can send in a prescription if you can find a pharmacy that has it. I've been keeping both 1 and 2 milligram of semaglutide or 10 and 12.5 of tirzepatide on the med list so that the patient can go, if they can't get the dose that we're prescribing, they can back and get the previous one, at least to keep them from being without medication. And I've even gone to oral semaglutide in some of my patients who are having, chronic long-term issues with availability of their medication. Probably the most vexing situation that I have is the people who really want this for weight loss, but don't want to pay the cost because it's not covered. And they're going out online or to, clinics that are setting up shop in our area. And there have been, reports of complications related to people taking these compounded formulations, including severe allergy, hypoglycemia. But I counsel my patients that, buyer beware, you don't know what you're getting. I am not prescribing it.
Absolutely. In addition to the potential risk that you've already mentioned, I've also heard that some of these clinics may be selling, for example, semaglutide salts, which are actually not expected to be effective either in glucose lowering or in helping people to lose weight. So it's not just that there might be potential risks associated with these formulations of the medications that can be available off-label. It's that they might not even work. So I would definitely discourage people from going that route. It's not clear to me that would be an alternative preferable to not taking the medicine at all.
So, I'm really interested to see your thoughts about the availability or the potential availability of generic liraglutide and what you think that's going to do to the market. I think it's this year that we may see our first generic product come on the market.
Yeah, that's my understanding as well. And there may be more than one company developing generic formulations of liraglutide. Now, what we've seen in recent years is often when generic versions of expensive medicines become available, they're not necessarily dirt cheap, but that over time, the cost can drop. And sometimes there are surprises because, again, if there's more than one company making a generic version, one of those companies may decide to make their version very inexpensive. So that would all be a really exciting and helpful alternative way to obtain use of a GLP-1 receptor agonist for diabetes or weight management purposes, depending on your particular patient. So I'm excited for that to happen, but I think it remains to be determined as to how much more of a bargain those are than the currently available formulations. One thing that's important to mention is that both Novo Nordisk and Eli Lilly, who are manufacturers of these medications, have announced an intention to sell the medicines direct to patients. I think out of concern that people were of course not able to access medicines that they had indications for, but also due to concerns about the safety of these sort of counterfeit or compounded medications that we've been talking about. And of course, it's not something that the person can write a prescription for themselves to get. There is a medical assessment and supervision, but we may see in the future a bit more of cutting out of the middleman in order for people to access these medications.
It's going to be really interesting to see the price points that they have, because I suspect they may be a little less, but what the benefit the patient's going to see financially with that. I don't know. I haven't seen any prices or any discussions of that as of yet. So stay tuned.
Yes, me either. I wouldn't necessarily assume that it will be a bargain to buy direct from the company, but it certainly would be safer than some of the alternative approaches that people are using. And it may help to minimize, in particular, some of the worrisome situations where people taking these medicines specifically for glycemic control are unable to find the medicine and then have a deterioration in their diabetes management. Carol, this has been a wonderful discussion. Thank you so much for talking today about some of the recent developments in the use of the incretin-based therapies. Do you have any final words?
No, I just think it was a really good opportunity for us to really address some of the headlines that our listeners might be reading and understanding the backstory to that.
I'd like to thank Dr. Green and Dr. Wysham for that excellent discussion, and thank you to our listeners for joining in. As a reminder, to view the full program on connecting the mechanisms of action to patient outcomes, integrating the latest treatments for type 2 diabetes into patient care, on the Clinical Care Options website, click on the link in the show notes for this episode. And please be sure to check back regularly for more episodes on important endocrinology topics. Thank you.